I'm Bob Blum, and the director of the Johns Hopkins Urban Health Institute. First of all, let me welcome you here to this absolutely spectacular facility at Humanum. It is unquestionably our favorite community convening site. It is just such a light, bright, and wonderful space. The planning for today's meeting began more than a year ago. It represents a collaboration of the ICTR, which is the Institute for Clinical Translational Research, and the Urban Health Institute. The ICTR, headed by Dr. Dan Ford, is really all about how you take research and link it with community efforts, community initiatives, and community priorities. The Urban Health Institute, over the last 7 years, has focused tremendously on collaborations. Over the last 5 years, we have given, for example, over 80 small grants. We sponsor annually the Henrietta Lacks Memorial Award, which is about the best of community and university collaborations, and we were very excited that Safe Streets East and Living Classrooms was the awardee this year, and Sisters Together in Reaching was the runner-up. We sponsor numerous forums that are all about collaborations. Just last week in this very room we held, no, that was 2 weeks ago now. How time flies when you're having fun. 2 weeks ago in this very room, we had a meeting of community partners on planning the next Social Determinants of Health symposium that we'll be holding in April. So who are our community partners? Those who choose to collaborate and work with us. We have much to learn from our community partners, and hopefully, as an institution and as individuals, we have some to offer as well. We see this as a partnership. The planning for this meeting, however, was not just among those two entities. There was a fabulous community and university group that planned today's meeting. And I'd just like to acknowledge those who were here. Leon Purnell was part of that group. Jackie Sharp-Massey, who is over there. Leon, who is behind the lights there. He'll be in front of the lights later, has been part of the group, as has Dan Hale, Sarah Morris-Compton, Darius Tandon, who subsequently went to Northwestern University, and Andrea Galen. We met a few times, crafted the program, and the people who have been instrumental in operationalizing that plan include Maren Solomon, who is in the back as the registrar, Amy Gawad, Liz Toft, and particularly Eric Rice, who's a professor in the School of Education and Associate Director of the Urban Health Institute. In a moment, I'm going to turn it to Eric But I would also like to say that there are numerous entities at Hopkins committed to and working in and with the communities of Baltimore. I had an experience not terribly long ago. About a month ago, I got an email from the Dean of the School of Public Health. He said, Senator Cardin is coming next Tuesday. Can you find out what exactly we are doing in Baltimore and in Maryland? Now, you would think we would have a database. Hopkins, guys, is so profoundly decentralized. Even though it sounds like it's a single person, there is nothing that represents any single entity at Hopkins. And so there was no information base. I sent out an email to the department chairs in the School of Public Health. They sent it out to all of the faculty. And in 5 days, we got 130 names of specific projects. Not like, oh yeah, I walk down Eager Street once a year. Specific projects of what people are doing in Baltimore itself, and then far more in Maryland more widely. We do a tremendous amount. But also do other schools, and I would also like to draw a particular note, and I'm going to be leaving it in the back, the work of Government and Community Affairs. They put together a community engagement inventory. They update it on an ongoing and regular basis of just an extraordinary set of resources throughout our community. So I wanted to bring that to your attention as well. I look forward to this afternoon with great anticipation. We have fabulous people speaking, and that includes every single person who is sitting at every table around this room. But let me turn it to Eric for further introductions.
Hi, my name is Eric Rice. Thank you, Bob, for the introduction. I am delighted to have you all here today. When we started working on this about a year ago, we had a number of goals, but what we really wanted to do was bring representatives of both Johns Hopkins and of the wider community together to look at some of the lessons that have been learned from these over 130 partnerships that Hopkins has had. But we also really wanted to learn from national models and not limit the conversation to what's been happening here in Baltimore. So I'm delighted to introduce our first panel, which is going to be about some national partnership models. So I'm going to introduce all three of them right now, and just in the order in which they'll be up. But first of all is Peggy Shepard, who is the Executive Director of We Act for Environmental Justice. She has successfully combined grassroots organizing, environmental advocacy, and environmental health research to become one of the most highly respected environmental advocates in the country today. So yeah, why don't you guys just step up. And she's been a pioneer for advancing the perspective of environmental justice in urban communities, and to help in ensuring that all people have access to clean air, water, and soil, and that extends to all people and communities. And she's going to talk about the partnerships that she's established in New York and some of the lessons learned there. I'm also delighted to have, they'll be tag teaming Jennifer Schaal and Geni Ng. They're up from Greensboro, North Carolina. Jennifer Schaal is president of the board of the Partnership Project, which is an anti-racism training organization in Greensboro, North Carolina. And she's a founding member of the Greensboro Health Disparities Collaborative, for which she served as co-chair. Geni Ng is a professor of health behavior at the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. And she has over 30 years of experience with community-based participatory research, including field studies conducted with rural communities in the U.S. South, and all the way as far away as sub-Saharan Africa and Southeast Asia, much of which addresses stigmatizing health problems such as pesticide poisoning, cancer, and STIs and HIV. So I'm delighted to welcome you here today, and we'll be beginning with Peggy Shepard. So Please join me in welcoming all three.
Good afternoon, everyone. I'm going to start out by giving you a little background about where I work and some of the partnerships I've been involved in over the past 15 years. So I've been working for 25 years at We Act for Environmental Justice as the founding executive director and co-founder. And I've been engaged in the grassroots national environmental justice movement, which has really redefined environment to embrace all the habitats where we live, work, play, and go to school. And movement organizers, advocates, and academics have helped document that millions of people in this nation do not have access to clean air, clean water, a healthy home, a safe school, and a sustainable community. And so I realize that we live and work in a context of race and class and income as key determinants of health status, environmental protection, and how land use burdens and benefits are distributed. So I live and work in northern Manhattan, an area of 7.4 square miles with over 600,000, mostly African American and Latino residents with a median household income of $16,000. It's a non-attainment area for clean air standards, ranked #1 in cancer risk from air toxics by the EPA, and has some of the highest asthma rates in the nation. Multiple environmental exposures, high proportion of learning disabilities, and excess mortality from asthma, cancer, and heart disease. So my organization got started back in 1988 as a direct result of West Harlem's protest over the disparate burden of pollution experienced by residents due to the operation of a sewage treatment plant, which emitted odors and emissions. And so we went to work organizing the community for 8 years and sued the city and got a $1 million settlement of our lawsuit against the city. And the city committed $55 million to fix the plant over a 5-year period of time. And so we realized that we needed to institutionalize a strong advocacy voice in an underserved community so that we could engage community residents in the environmental decision-making that really governs their lives and communities. And so we accomplish our mission through community organizing, education and training, advocacy and research, and public policy development. We lead local, state, and federal campaigns on children's environmental health, climate justice, transportation equity, and chemical policy. So over the last few years, fortunately, there's been a growing awareness of community conditions that affect community health and sustainability. Community-wide environmental conditions influence health directly through toxins in air, water, soil, and building materials. And health disparities are prominent in communities without access to nutritious food, spaces for active living, effective transportation systems, but with ready access to unhealthy products like cigarettes, alcohol, and fast foods. And when you combine these factors with the lack of access to quality medical care, then we really describe the landscape of disparities in communities like northern Manhattan and the South Bronx and Baltimore. So the research that we've been involved in, well, let me just step back and say, why have we been involved in partnerships for the past 15 years? Most of our partnerships have been at 2 research centers at the Columbia School of Public Health. One is the Basic Research Center funded by the NIEHS, the National Institute of Environmental Health Sciences, and the second center is the Columbia Children's Environmental Health Center that's funded by EPA and the NIEHS. So we got involved because residents wanted to understand the community-level exposures they were experiencing from the sewage treatment plant and the numerous diesel bus depots that are housed in our neighborhoods. So we received a pilot grant from the NIEHS Center to conduct community-based research with our youth and with researchers like Pat Kinney and Mary Northridge at the Mailman School of Public Health. Our study documented that diesel exhaust exposure among adolescents in Harlem were an important contributor to reduced lung function in 75% of the junior high school students who participated in the study and who did not go to a school on a heavily trafficked street. Those study findings were published in Environmental Health Perspectives and provided a strong basis for our campaign to reduce asthma incidence through stronger clean air policies, diesel bus retrofits, and a cleaner Metropolitan Transit Authority bus fleet, because over 1/3 of those buses are housed in uptown neighborhoods. Now, another study between WEACT, which is my organization, and the NIHS Center was called Airborne Concentrations of Fine Particles on Harlem Sidewalks. And this research led to the EPA Region 2 initiating the first community-based air monitoring in New York neighborhoods. And the monitoring data was considered in setting the EPA's fine particulate standard, which was upheld by the Supreme Court in the last days of the Clinton administration. So we have been able to promote data from the funded centers in helping to clean up a bus fleet. There's now diesel retrofits in every single bus. It was an 18-year campaign, I should say. We also have now developed a community task force that has worked with the Metropolitan Transit Authority, and which is now building the first green bus depot in the country. And so we've had a community task force meeting for 6 years around that redevelopment. Now, more recently, data from the centers has been on pesticide exposure in the home, and it's really helped us to testify and educate legislators who have passed new legislation on pesticide notification and use in schools. A small technology grant from the center allowed us, with a grant from the state, to conduct a project demonstrating the best available technology for retrofitting the crankcase of school buses, which you probably know are the dirtiest vehicles on the road, and that a child is more exposed sitting inside the bus than standing outside near the tailpipe. And so the City Council finally passed legislation mandating engine retrofits of all school buses, and our study helped us advocate for the best available technology to be used, not the cheapest technology to be used. And so we face another challenge with endocrine disruptors, which are chemicals found in plastics, and also in a lot of the personal care products, cosmetics, lotions that we all use in our homes. They have names like BPA and PBDEs and flame retardants. You've probably heard some of those names. They're under close scrutiny by the EPA, and they have very negative effects on residents. And so we've been able to use this early data to promote chemical policy reform at the state legislature, where 2 years ago we were able to get a bill passed that banned BPA in children's products, but only children under the age of 3. So the chemical industry is just very powerful in stopping comprehensive chemical policy reform. So our 15-year partnership has really answered community questions about levels of indoor and outdoor toxins and allergens. It's engaged residents, helped us empower them through trainings, evidence-based environmental health campaigns that have impacted public policy. We believe the collaboration has enriched the science and increased capacity at the community and the academic levels. And we know that research that's committed to strong science, high-level community involvement, and the strategic use of study findings to help impact policy is really an important contributor to the broader struggle for urban health and environmental justice. So what do we mean by community-based participatory research? Well, one definition is that it's a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. It begins with a research topic of importance to the community, has the aim of combining knowledge with action and achieving social change to improve health outcomes and eliminate health disparities. And it's really important that there's been a renewed focus on community-engaged research, because it really increases our understanding of the complex factors that affect health, and the importance of both qualitative and quantitative methods, and the need to translate those findings into interventions and basic and applied research that really can create changes in policy and practice. So I think as a result of participatory models of research, communities become actively engaged in the process through partnerships with a range of academic institutions. And I think that work has become central to the National Prevention Research Agenda as articulated by the Institute of Medicine, the CDC, and others. So in thinking about what I've learned after 15 years of partnerships with 4 different universities, there are a number of things I'd like to share. And the first is that an essential basis for effective and authentic partnerships is that all partners establish their own power and their legitimacy. And we know that organizational mission really matters. And so a clear sense of purpose and organizational goals are really prerequisites for forming effective partnerships. However, there is a necessary tension between activism and research, and that often may take a number of years to fully appreciate those tensions and where your research partners and community partners may be coming from in terms of their perspectives. We also have to ask ourselves, what's the larger vision? A visionary goal that's larger than any of the independent goals is really necessary for partnerships to be effective. And your larger visionary goal may be to move toward a healthier and safer Baltimore using strategies arrived at through a consensus with your partners and other community leaders and policymakers. Certainly central to the success of the partnership will be that the partners are rooted within the affected community and that there are clear objectives, expectations of the partners, though we all know that certain aspects of a project may fall disproportionately on one partner or the other at different times. We know that disagreements and conflicts will arise over time, so written agreements to help clarify the objectives, responsibilities, and a scope of work is essential. My experience is that partners over the long haul are mutually supportive without forcing one another to buy into each other's mandates and goals. And increased demands on the partnership can be satisfying, can be time-consuming, but also very critical. Things like increased speaking engagements, press conferences, researchers speaking at workshops, and joining government advisory groups that are important to regulation in our communities. One intangible reward that turns out to be quite tangible is that we're all changed by that process of partnership, especially when we have worked effectively over a long period of time. And I think an important outcome is to have a series of interrelated funded projects where researchers and community leaders are communicating constantly throughout the year, not just on a one-time project or, going your separate ways once the funding is over. But then we have to ask, how does all this happen effectively in a university-wide basis? Generally, a community will find a researcher or a set of researchers or a center, and that center is great. The rest of the university may not have a clue, but they found 1 or 2 really great individuals to work with. And we obviously know that over time, that is not very sustainable for a number of reasons. People leave and change universities. What we found is that the junior researchers we once worked with become senior and then don't need those smaller grants anymore. Sometimes they get their own centers, and so they're much too busy with their own research agenda. So again, how do we sustain these issues. And clearly, you all here have thought about that with the Urban Health Institute. And we realize that institutional commitment by not only academics, but there has to be institutional commitment on the part of your community-based organizations as well. Otherwise, you don't really have a partnership. There needs to be support from the funders. When we look nationally, CDC has funded health promotion centers that mandated community engagement, started that maybe 20 years ago. The National Institute of Environmental Health Sciences mandated community partners in their research centers, and they allowed community-based organizations to become principal investigators. That was under the old director who is now gone, and so they've no longer, do I believe, community PIs are really, really going to get through the peer review process. So that's unfortunate, but that's a reality. But as a PI, clearly it gives you managerial and financial control. It gives you important visibility and accountability at the federal level. And it helps to refine the community organization's research agenda and to influence that agenda at the university. But even when funders are supportive, there still remain challenges. For instance, how do we compensate community partners? Big issue. A subcontract is great, but we all know that that can take sometimes a year to get set up. I remember in the first couple of years with a partner, they were a year and a half behind on about $150,000 to us, and we were at a point where we almost couldn't make payroll. And so we had to really reach out to the dean and say, you know, grants and contracts has to change. You know, you've got to monitor this and help us with that. And so that never happened again. But when I talk to community groups around the country, that is a huge issue. And the fact that often compensation is on reimbursement. So an organization having the upfront money to hire someone or pay someone's salary or convene meetings without upfront money can be obviously very difficult for struggling nonprofits. Again, how do you sustain relationships with researchers as they climb the tenure ladder? Again, that's something that the university needs to begin to think about. Also, I find that IRBs, institutional review boards, are behind the curve on CBPR. A lot of universities will not cover community organizations for collecting data and doing the field work. We have a 4-year partnership project right now with the University of Pittsburgh, and their IRB decided they would not cover my organization to do focus groups and other work in New York City. So we had to go and find our own independent IRB. We had to foot a bill which has gotten to about $3,500 so far. And the university said it wasn't in the budget, and we're not going to reimburse it because that's the cost of doing business. Well, it might be the cost of doing business if you're a university, but not if you're a community-based organization. And so, again, some of this work requires researchers to be activists within their own institution to really ensure that some of these processes are changed to really allow effective partnerships. I've also found that universities should encourage researchers in city and state policy and government advisory boards. You often have researchers who work for industry who are on these policy setting regulatory boards, and we need more folks from schools of public health and medical centers to sit on those boards as well, because again, those folks are coming with a very different perspective about community, and it's important to have that perspective on many of these advisory boards. Certainly more controversial is how universities promote equitable land use and siting policies. You know, we've had a 15-year partnership with Columbia, but when they decided to expand into West Harlem in the only remaining vacant land left, some of the community looked at us and said, well, you're a partner of community, so you're supporting this. And in fact, we did not support that. And again, a lot of people don't realize how decentralized universities really are. So the downtown administration on one campus is, developing their capital campaigns and, expanding their campuses. The School of Public Health is 40, 50 blocks further uptown without any real knowledge of any of that's going on. So again, land use and siting is a very real issue in low-income communities where universities are based. And then again, I think a university's values are clearly described by their promotion and tenure policy and by the criteria used to evaluate faculty members. There is something called the Community Engaged Scholarship for Health Collaborative. It's a collaborative of 10 health professional schools, and they've come together for two goals: to provide national leadership for creating a more supportive culture and reward system for health professional faculty involved in community engaged scholarship, and secondly, to develop and disseminate a set of tools that faculty and health professionals can use to advance community engaged scholarship. And they recommend that the federal funders of research and academic institutions should recognize and reward faculty scholarship related to public health practice, and that funders should mandate partnerships where appropriate. Also, they look at the idea that academic institutions should develop criteria for recognizing and rewarding faculty scholarship related to service activities that strengthen public health practice. They recommend that schools of public health provide increased academic recognition and reward for policy-related activities. Most academic institutions confer tenure and promote faculty based primarily on the quantity and caliber of peer-reviewed publications. But as we know, if you don't have a partner that is taking that research and translating it into policy, most policymakers, unfortunately, are not reading peer-reviewed publications. I can't tell you how many people from state departments of health and city departments of health, will ask me, well, what are the asthma findings? What's the research that's going on? They're not reading those journals, yet they are the ones on the cutting edge of developing regulation and policies that affect our lives. They also believe that it's important to develop and disseminate a set of tools that faculty and health professional schools can use to advance community-based scholarship. However, they recognize that a lot of the products of community-engaged research are not currently peer-reviewed. And so as a result, many people recommend that a national board should be established to facilitate a peer review process. There have also been recommendations that special IRBs should be set up just to review community-based participatory research projects, because the average IRB at universities do not have much experience in that kind of research and have rules that really are more clinical in nature than community-based. So again, those are ideas, and a number of community groups around the country have begun to develop advisory boards that review research at particular centers that they are connected to. And so there are numbers of best practices from around the country. At the Mount Sinai CTSA board, which I'm a member of, I co-chaired a capacity building committee where we designed a community-based research course. It was basically a research 101 that focused on identified needs of community groups, which we assessed through a survey. And so the 10-session course really focused on program evaluation and survey design, which were the two elements that most CBOs were most interested in. And so we, out of, our pilot was 10 groups, 5 finished the course. And certainly, the academic institution has to invest in that staffing time and effort along with the CBO partners who aren't funded for those activities and have to help coordinate and assess curriculum and, you know, develop that educational model. Some other universities are developing engaged learning zones where multi-year place-based projects focus university resources on a specific community in order to increase their leadership capacity. At the University of Michigan, there's an Office of the Vice President for Research that helps develop policy and CBPR university-wide. And the credibility and visibility of that office is important to the credibility of CBPR policy. UMich is also working on the concept of a community engagement corridor. It's a real ambitious initiative out of the President's office that would coordinate CBPR policy and practice among a number of universities in that region of Michigan. And so clearly, those kinds of initiatives really require savvy, proactive researchers to create that kind of change that we need in terms of town and gown, and the change they need to increase the stature and culture of community engagement within their institution. So I believe that advocates should start with the dean of their school, who should begin a dialogue with the university president on this issue. Deans should meet with the provosts and the offices of research to coordinate policies. And I think there are a number of other activities and initiatives that can lead to substantive culture change. Institute a CBPR curriculum with doctoral students. Recruit faculty of color who are interested in community-engaged work. Note the importance of the role of senior professors to mentor junior faculty, and increase the support and research agenda to apply and translate research into policy. And I think most importantly, CBPR requires institutional funding support. New faculty, I'm told, get research development funds, packages of $50,000 to $300,000 for startup funds, yet there's no funding for core infrastructure for engagement with communities in most universities. Some centers are promoting their pilot grants to junior investigators that allow them to gather preliminary data, hire graduate students, develop relationships with community groups, and develop their capacity to apply for larger R01 grants. But as we know, the ultimate test of any effective partnership is whether we can really work together to measurably improve the health and environments of communities like Harlem and Baltimore. And again, we've got to engage the interests of everyone, the elected officials, the adults and the youth who live in the community, the press, other scientists, if we're really going to begin to reduce the excess morbidity and mortality that is escalating throughout communities of color and low income. So let's all work to be the change that we're hoping for and that we're seeking. So thank you very much.
We're going to move right on to our second presentation, and then we'll have a little bit of time for Q&A for the panel afterwards.
Good afternoon. Good, you're from the South, all right? You respond. I'm Geni Yang, and I am the academic partner of the Greensboro Health Disparities Collaborative. And I want to thank Eric Rice and Liz Toft and Amy Gowad and Darius Tandon for actually inviting us to be here for this wonderful event.
And I'm, excuse me, I'm Jennifer Schaal. I'm one of many of Geni's community partners. And I want to bring into the room that all of the other members of the Greensboro Health Disparities Collaborative who are co-presenters in spirit. And I want to thank Geni for practicing what she preaches by always trying to have one of her community partners with her when she presents.
Yeah. So today we're going to lay the groundwork. We plan to share with you today a different way of thinking about community engagement. That community engagement is one approach, it's not the only approach, but it's an approach we're going to talk about today for making implicit bias in public health practice transparent and for increasing the accountability for equity in the quality of public health services, public health interventions, and public health research, regardless of race and ethnicity, tribal affiliation, gender, sexual identity, or disability. To start, I'm going to request that, at least for the next 25 minutes, that we suspend either-or thinking, that we suspend notions of dichotomies, and instead that we embrace the joining together of contradictions. And one way of, I'm going to start off is by using the metaphor of a bowl. So in my culture, a bowl is very important. We use the bowl for eating. We use it for drinking. We use it for scooping things. On our wedding day, we use it to offer respect to our parents. On New Year's Day, we use it to recognize and to give thanks to our ancestors with the bowl. So what the bowl is made out of, the physical material, is very important. The bowl needs to hold hot as well as cold. It needs to hold solid as well as liquid. So it can be made out of plastic, like this one, or expensive porcelain, and highly painted as that one. The dimension of a bowl is also very important because it needs to fit in your hand. When you put it down, it shouldn't roll over. And so a lot of care goes into shaping the bowl and making the bowl. But what the Chinese say is important about the bowl is the empty space. If there were no empty space, it wouldn't be a bowl. If there were no physical dimensions, it wouldn't be a bowl. But what the bowl represents is the joining together of contradictions. The outside physical features represents boundaries, control, limitations. The empty space of the bowl represents room, freedom, and opportunity. When you join these two opposites together, it forms something very magical, very mystical, that is very different from the original sources. So we say we can think about dualities, the joining together of opposites, the joining together of contradictions, and the tensions that come up when you have conflict. But it forms something very magical. In public health, we often say that for those of us who are academics, problems of disease, illness, and risk are selected based on epidemiological data. We do literature review, right? That's as an outsider. We're not the people who experience those problems on an everyday basis. We're outside of those. The insiders, those who are the intended beneficiaries of our research and of our practices and our services, they may select issues based on their everyday life experience. And so we say insiders and outsiders' views on what's important for public health are almost always different. They're never the same. So what do we do? How do we then try to bring these contradictions together, the insider's view and the outsider's view? Also, we say that effective and sustainable interventions are informed by theory and best practices from other studies, right? Evidence-based practices. Whereas from an insider's perspective, it might be that effective and sustainable interventions are informed by the concerns and assets and culture of the intended beneficiaries. And so what happens when we, as outsiders, we know that health and culture are intertwined. And so what do we do to try and, when we think about either or, their culture, my culture? We've come up with this notion of cultural competency. We arrogantly think that we can become competent in somebody else's culture. and that a 2-hour training would do it. And if it's mandated by the Federal Office of Minority Health for all medical students, it's going to work. That's when we do either-or thinking to become competent. What we say here to bridge this, maybe the bridging, the joining of these two cultures is the concept of cultural humility. That if we can be humble enough to know that we cannot ever know somebody else's culture, and that culture is different, but we need that culture at the table. And so recognizing that there are different perspectives and different priorities, recognizing that there are different cultures, and we're not trying to become an insider, and we don't expect insiders to become outsiders, is an important part of community engagement. And maybe not everybody can do community engagement. So I'm going to move on now for Jennifer to talk about how do you form a common vocabulary.
Part of my role here is to give you some idea about the history of the Greensboro Health Disparities Collaborative and how we came to build that partnership. But I want to start by asking a few questions about community academic partnerships and how decisions are made about the formation. We like to think, we like analogies, I guess. We like to think about setting a table and talk about who it is that sits at the table. How do you bring community members to the table when, for a multitude of reasons, they often have mistrust of the system? How do you bring academic partners to the table, professionals to the table, who often come with an agenda that they already want to deal with and are therefore reluctant to relinquish control, to really sit as equals at a table? And once you get there, whose issues get to come to the table? The community obviously have their own issues that they need to deal with, and often academics have a set of agendas of their own, of direction that they want to see their research go. So who gets to bring their issues? And who sets the table? Who makes up the design? Who gets to decide on the structures that are being used for decision making? How does the budget negotiation go? Who gets to decide how the plans are implemented? Who gets to decide and has ownership for dissemination of the products? The parent organization for the Greensboro Health Disparities Collaborative is the Partnership Project. And prior to the formation of the Partnership Project, the mayor of Greensboro back in the late 90s had mandated the formation of a task force. We're all familiar with task forces. And the task force was called Project Greensboro, and Project Greensboro was set up to fix social problems, teenage pregnancy, neighborhood decline, et cetera. And this task force went on for several years. They worked very hard. They did accomplish some visible changes in some neighborhoods in Greensboro. There were some better street lights. There were better looking streets in some areas. But the big issues were unchanged. So two of the members of that group, Nettie Code, who was a community organizer, and Suzanne Plisick, who was also a community organizer, joined with a professor from Guilford College to establish the Partnership Project in 1997. And their goal was to bring neighborhoods into partnership with the city of Greensboro and other community members to try and help teach communities how to take responsibility for themselves and how to bring about those changes. Not long after they got started, they had an intern working with them who asked them the question, why are people poor? And introduced them to the People's Institute for Survival and Beyond, and totally transformed the organization. The People's Institute for Survival and Beyond was founded in 1980 by two longtime community organizers, Ron Chisholm and Jim Dunn, who had spent many years organizing in communities and trying to bring about change, and who had come to the realization that they needed to understand why are people poor, to understand how to work in communities. And they realized that in order to change and uplift communities, they had to address racism, culture, and history, and that they had to look at the systems and how systems functioned. So they developed the Undoing Racism training as a need to create strategies to develop wholesome communities. Instead of developing projects, develop communities. So in 1999, the Partnership Project changed its focus from fixing communities to trying to address systems, and it became an anti-racism training organization with the mission to educate partners in understanding institutional racism and then how to determine strategies. We want to give you a little bit of an overview of the Undoing Racism training. And the training is 2 days of intensive interactive dialogue and learning experience, which includes these 5 phases. In the first phase, it's an exercise and some work to try and get people to understand the paradigm they're in and how to shift that paradigm. The next phase looks at historical and current relationship between institutions and communities, and then does a power analysis of how the institutions and communities interact with each other. The third phase is trying to get people to take ownership of the role of gatekeeping in their work, and looking at accountability and internalized racial oppression. It then moves on, at this point, this is 1.5 days into the workshop, to defining race and racism, because it takes all that background work to really get to a point where people can have that conversation. And they look at how race and racism manifest in institutions, linguistically, culturally, and individually as well. And then the final phase is to talk about how the institutions impose their values and culture on communities they serve, and the issue of internalized racial superiority. So once the Partnership Project got started on anti-racism training, it's been about 15 years now, and hundreds of members of the Greensboro community have been trained. And the focus was really on trying to get key community members, people in the school system, people in government, people on foundations, people in social services, churches, law enforcement, colleges, universities. And we have successfully trained 4 of the last 5 mayors of the city, so we're pleased with that. But sharing the experience and the language of undoing racism has allowed the members of the Greensboro Health Disparities Collaborative, which is developed out of the Partnership Project, to be more open. We have a common vocabulary. We don't have to worry quite as much about being politically correct, but we can be clear about what we're talking about. And this diagram here is a diagram of the power analysis that's developed in the Undoing Racism training. So the next phase in the partnership, after starting to get people in the community trained, was another intern was working with the partnership and introduced them to the Institute of Medicine study, Unequal Treatment, which was published in 2002 and looked at health disparities. And the definition of disparities in that report was racial or ethnic differences in the quality of health care that are not due to access-related factors or clinical needs, preferences, and appropriateness of intervention. So when this came out, the Partnership Project decided that one way to focus their energies was to look at systems in healthcare and health disparities. So they applied to a local foundation, the hospital foundation, the Moses Cone Community Foundation, and received a planning grant to develop a collaborative which was grounded in the principles of undoing racism, and to develop a proposal to engage in research. And this led to the development of the Greensboro Health Disparities Collaborative in 2003. But I think what really makes our collaborative unique is that it was a community organizing initiative that brought the collaborative together. The community did some research, became familiar with community-based participatory research, and took the initiative to look for and interview possible academic research partners at the University of North Carolina at Chapel Hill to address race-specific inequities. That's how we got to know Geni. So this is the Greensboro Health Disparities Collaborative, which is the result of the organizing efforts. And it is a community, academic, and medical partnership. The mission is to establish structures and processes that respond to, empower, and facilitate communities in defining and resolving issues related to disparities in health. There are approximately 25 members. It's multiracial, multi-ethnic, multidisciplinary. There are representatives from neighborhood organizations, hospitals, retired school teachers, grad students, professors, and people who are Christian, Islamic, and Jewish. In addition to this work, 2 of our members from the partnership project have gone on to incorporate another organization called the Racial Equity Institute in Greensboro, which is an alliance of trainers and organizers who devote themselves to the work of anti-racist transformation. So they are our partners, and they continue the 2-day trainings, but supplement it with an 18-month to 2-year process, which is to help leaders and organizations who want to proactively understand and address racism, both in their organizations and in the communities that they work in.
Thank you. Good. So I'm going to just describe for you very briefly, kind of like, so the last 10 years, after we formed the collaborative, and then the research that we undertook to address inequities in breast and lung cancer outcomes among African American and white patients at Cone, which is one of our partners at Cone Cancer Center. And our second grant, it adds on a second site, which is the University of Pittsburgh Hillman Cancer Center. But what you have in your folders is you have an article that actually describes how we integrated community-based participatory research principles and the Undoing Racism training by the People's Institute for Survival and Beyond. So it describes the training in more depth and what we did with it, the process we undertook over the 18 months, and then the process we used to write an NIH, well, a National Cancer Institute application for an R24, which is about $250,000 for 2 years, to do an exploratory study, which was funded, amazingly. And it was funded, and it was like the first foray of the Greensboro Health Disparities Collaborative in actually doing scientific research. And it tells you about the different workshops we did and how we decided that, and how we actually wrote an NIH grant as a group, as 25 people, you know, with academic and community partners and medical partners, and got it in and got it funded. Okay. You also have in your folders, what things we're going to talk about now are, we have therefore instituted different structures in the Greensboro Health Disparities Collaborative to ensure equity in decision making, not only for how we run the collaborative, but also for how do we, what our values are, what our bylaws are, and then also for co-authorship, guidelines for co-authorship and co-presenting and dissemination. And we also have for you, you have in here, there's a whole chapter that we wrote, which is in a book called Methods for Community-Based Participatory Research for Health. And I guess the chapter is loaded on the website for the Urban Health Institute. It was too big to stick in the folders. And so if you're interested, you can download that chapter, which describes in more detail what we're going to cover right now. But as you see, so the first study is Cancer Care and Racial Equity Study, CCARES. And so we also had a little bit of funding from these other foundations because, as you know, NIH doesn't pay for food. And so we needed to get more money for food for these meetings and for celebrations and dissemination. And then the second one is Accountability for Cancer Care through Undoing Racism and Equity. So CCARES, the question we were asking, and it took us several months to come up with a research question, did African American and white women with breast cancer in Guilford County, North Carolina, receive treatment at Cone Cancer Center that was the same? So we're not on the individual level, we're at the institutional level. That's what Undoing Racism does. It helps you to start thinking about implicit bias at the institutional level, not at the patient-provider level. That's prejudice. We're talking about institutional racism, which is structural. Okay. And then the second research question was, if the breast cancer care was not the same, how was it different, and what could have been the reason? Okay, so do you see the difference there of really trying to get at systems change? And so we use the results from that to then justify what we think would work as a systems change intervention at 2 cancer centers. And it was Michael Jonas who got his doctoral degree here, and then he went to, got a postdoc, and now he's at the University of Pittsburgh. And so he introduced Undoing Racism and CBPR at the University of Pittsburgh Cancer Center. And so that's why we have these 2 sites. Now, these are very kind of progressive, I think, cancer centers who are willing to look at structural, institutional ways that the cancer care is organized that seems to have race-specific outcomes that are different. Okay. All right, so we're going to start first with the full value contract, and Jennifer will describe that.
A part of the Undoing Racism that's very important is to ask members of the group to abide by a set of guidelines for behavior. And I'm sure all of you have been in groups where guidelines for behavior have been put together. But using that model, in the early months of the formation of the Greensboro Health Disparities Collaborative, we put together a set of behavioral standards which would guide our interactions. And we developed over time a specific contract which is that addresses the unique components of our partnership. Within our full value contract, there are several sections that we feel need to be addressed. One is to really focus on the fact that each member of the collaborative is valuable. Regardless of their background, they have unique experiences to bring to the conversation. Other sections include a list of values that were determined by our group, and those can vary from group to group, but it was a set of guidelines that we put together in a very interactive way to try and come up to agreement. And the way that we use the full value contract is sort of as a touchstone when there's a problem. And we find that reviewing it on a periodic basis, probably at least annually, is good. And we've even done a re-signing of the full value contract, sort of as a formal way of saying we still adhere to these principles and we think that they're important. This is a sample of our full value contract. It starts with general statements about our goals and how we work together and the belief that each member has value. And then you can see in the middle there's the list of the values that we share. And it closes with a commitment to common ownership of any products, research, or otherwise that are developed by the collaborative.
You also have in your folder are the bylaws for the Greensboro Health Disparities Collaborative. I think Peggy mentioned the importance of thinking about the organization, organizational structure. It couldn't be, this is maybe a little, this is kind of formal for some people. For other people, it's not very formal. Working with tribal nations, for example, they become much more formal with regards to what is the collaboration and how are decisions going to be made. And so that is also in your folder. It's called Collaborative Bylaws, and it's adopted, and it's been amended, actually. We've amended it once so far, because as the partnership evolves, it's important for you to look at those bylaws to see if they still work. I want to point out for you is that partnership name, so that took us a while to have an actual name, but and then the governance structure. So we have co-presidents. We don't just have one president. The co-president is never an academic. It's always a community person. We have secretary, treasurer, et cetera, and we have different committees on it. But I want to point out here for the mission statement and goals, as Peggy referred to earlier, we as a collaborative, and I'm a member of other collaboratives, but this particular collaborative did not want the mission to be focused on a project. I've been members of other collaboratives where it's based around the grant, It's based around the study. It's based around the project. And so then if you get another project, then you do a different set of bylaws. With the Greensboro Health Disparities Collaborative, this was like a prenup. We were in this for the long haul, and that this was a permanent partnership. And that, as you saw, the mission is so complex with regards to systems change, addressing institutional racism. One or a couple of grants is not going to do it. It's going to take more than 10 years. And so we put in a mission and goals that were for long-term collaboration. And the guiding principles, we wanted to make sure they reflected undoing racism principles as well as the CBPR principles, and the composition of membership and voting, et cetera. Okay. I think that's it. Okay. And then you have the sample in your folder. Many others have used these bylaws. You can certainly take them and think about how they would work for you. All right, and then another thing that we've developed, and these are also in your folder, are guidelines for co-authorship and how to ensure equitable dissemination. And so we don't just mean peer review journal articles. Classroom lectures. So if I'm going to do a guest lecture, or if any of us in the academics are going to be doing lectures about the project, about the fundings, it's important for the collaborative to see my slides and to see what I want to say, so that there is a review. Everybody will agree on that. Newspaper articles that they put in, they appear on local channels, Channel 8, the local channel, you know, talk shows, call-in shows. Okay, where they also, so we want to hear, we want to see what the press, what they're going to say about our collaborative. Community forums, we do a lot of those. I'm sure you do too, in terms of raising awareness, or if you're at health fairs. So all of these are dissemination, but we feel it must be shared with regards to respecting the values, and that reflects what everybody understands about who we are and what our work is. The last three here are poster presentations, you know, at conferences, oral presentations at conferences, and peer-reviewed journals, which is much more the academic. And so these guidelines also address those as well. And we define what it means to be a co-author, and what the sequence will be to determine who's first, who's second, who's third. You know, all those things, which I think we should be doing anyway in academia, but especially here with regards to how it goes and what happens with rejection, et cetera.
Well, and I think emphasizing that it's not just the writing process that's important in the authorship. Mm-hmm. It's the thought process that goes into deciding what the content is. And, you know, we have members of the collaborative that probably would not function very well as writers of an academic paper, but they certainly can contribute to the concepts and the way that we analyze the information.
Okay. All right. So now we're going to talk. And then this is something that the community was really great when we were presenting our findings, is that it was important for us to present, especially findings, you know, new knowledge about themselves. Was, you know, we had 50 breast cancer survivors, half African American and half white women, who really are very, very private about not letting other people know they have breast cancer. But we wanted them to be the first to hear the findings before we presented it to anybody else. And so with that Lance Armstrong money, we had a private dinner for them at a nice restaurant. We presented the results, and we discussed the implications with them for the next grant. And then we invited, and then the second group we needed to present to privately were the doctors at Cone Health. The doctors, the staff, the navigators. What were the findings from this study? And then we finally had the public forum at the library of Greensboro, where people were invited to come, and some of the physicians came, and actually a couple of the breast cancer survivors came and stood up. But it was very important, and it was something I learned. I never would have thought of this, you know, but it's the community who were the interviewers, and they know these participants and how important we should be with confidentiality. Okay, now. So, the elephant in the room.
The elephant in the room. As Peggy mentioned, it doesn't take very long in a community academic partnership to realize that money and budget can be a source of conflict and concern. Because of the way that funding institutions and universities function, it's very hard to achieve equity between community and university partners. Early in the formation of the collaborative, when we were working on our first grant, we bumped up against this right away. We had a deadline. We didn't have a finished budget. We did have a budget committee, but they had not finished their work. And because of the deadline, one of the academic partners decided that just to finish up the budget and submit it and get it dealt with. And it caused a splintering within the collaborative, and we lost a very valuable member as a result of it. And so we have learned that we need to be overt about our decisions, not covert, and that conversations about the budget can't just happen once. They have to happen over and over, and it has to be an ongoing process with both partners. Which is all to say we want to stress constant and careful communication. It's just essential to making a successful budget. The unique nature of community-based participatory research and community academic partnerships and the difficulty in achieving a balance of power makes us want to share this list of just a few things that we think are important. From the very beginning of the project, budget needs to be the conversation, and the community partners need to be involved in the beginning of the budget process, not after the budget's already been finished. And again, it needs to continue through the process. There needs to be a lot of conversation about community and CBO compensation. And that's always very challenging, trying to balance the different types of expertise that are brought to the table, and how do you value the different contributions of the partners. And our experience is that even as Peggy talked about, we can have a pretty good understanding of it, but trying to incorporate the giant umbrella of the university in this conversation is what it's an ongoing challenge. Capacity building is important for all partners, and you know, making this discussion a learning process is helpful for everyone. Figuring out what equity means for each partnership, because it's different. And the touchstones that we always go back to are accountability and transparency. Both partners need to be accountable to the other and transparent. And you know, the flip side of our problem with the budget was a later conversation that the community partners had without including the academic partners that also was a source of conflict.
I will add also, you know, during this time of funding, the sequester happened. Right now, the government shutdown has happened, and you know, this money is from NIH, and so trying to explain all that. But this project actually was able to get advances, a cash advance, and that took us meeting with the Vice Chancellor for Research at the University of North Carolina to show her the request for proposal that specified it had to be participatory. We had to have a community partner who was not just a subcontractor, but was actually a co-investigator. We showed her the proposal, and she went through all the different reasons and changed the rule. Not changed the rule. She found a loophole so that she could, through NIH, even with an NIH audit, could do that. It's still very problematic, but then as a result of that, as a result of finding out about undoing racism training and about the disparities and inequities that exist, they have paid for several staff members to go for undoing racism training, because they felt it was important for the staff who are going through these proposals to really understand institutional racism. So here's a couple of things with regards to necessary conflict. We say that conflict is necessary, and we learn from them. And what we use with a collaborative we call pinch moments. And this was brought to us by a consultant after we had a pinch moment with the budget of how do we tell people, you know, that we're not happy, you know, and I've been offended, or you've offended me. And so we say, you know, that if any member feels offended or thinks that things were not right, they say, I'm having a pinch moment. Then the group stops And then we ask the person, do you want to talk about it now? Or do you want to talk about it later? Because then we'll write it down and remember to bring it back up. It could be something as saying those people. And we have to be reminded not to say those people. And then people will just say, I'm having a pinch moment when you just said that. Okay. It could be something about bashing me as a university. And I say, I'm having a pinch moment. I've been with you for 10 years. Treat me, I want to be known as Geni, and don't bash me. So, and then with the budget. So a pinch moment. A 70% rule is what they use in Michigan, in Detroit, which is, it's not that 70% of the people in the room have to agree with the decision, but that each person in the room can at least get behind that decision 70%. So that you don't have to be 100% behind the decision, but you can at least be 70% behind it, and then that decision can move forward. Sorry. Language, jargon, that's one of ours. Don't say IRB, say Institutional Review Board. Don't say CBO, say Community-Based Organization. Don't say, just don't use those acronyms. It just drives people crazy. And then unclear agendas. So anytime we have a meeting, we send out an agenda for everybody to know ahead of time, and then we write up the minutes just to make sure that people who weren't there will know what's happening. Okay. And then this is our last slide.
One of the things that we like to emphasize is that both partners bring many assets to the table. And this is an asset chart that we've made for the partnership project and for UNC for what we have brought to this. Our community obviously has a lot of community initiatives since we pushed for this. Our Undoing Racism framework, our community organizing experience, our contacts in the community, the variety of members that we bring, and there's a lot of interviewing involved in the grants that we're doing, and that comes from community members. And if you ever came to one of our meetings, you would understand we also have a lot of passion. And then the academic.
Right, which is, well, there's nothing special here, but that we have been at UNC, have been engaged in CBPR, community-based participatory research, for a long time. Janice Bowie and Lee Bone here, they were the training site directors for postdoc training in CBPR, and I led the one at UNC. Barbara Israel, which led the one at Michigan. And so there are a lot of now faculty out there, our postdocs who are now junior faculty. Some actually got tenure, and it does bring to these particular institutions people who actually have these skills and that can contribute to them as well.
And I think the other part of it is that we bring these assets to the table, but we also take away assets. And the community partnership, a lot of people have gained skills in interviewing. We have learned and educated all of our members about institutional review boards and have done human ethics training with people. And in some of the analysis that we're doing, qualitative analysis, that is being taught to community members, and they're participating in the analysis. So there are many ways in which our assets are expanded.
Okay. All right. Thank you.
We're a little bit over time where we wanted to be right now, but we did get started a few minutes late, so we're going to take a couple of minutes for some question and answer.
I have a question that any of the panelists can answer. To what degree would you recommend or advise in terms of building the bridge, filling the gap between academic medicine? I think public health has done a great job as it pertains to community participatory research, but medicine is somewhat lacking in terms of really engaged in community effort. There's an interest, but we need to find out ways in which we can build better bridges. I think we have a curriculum, Genes to Society. We teach our medical students currently, so Hopkins has made some progress. But to get some feedback from those who have been in the trenches and getting some advice in terms of how we can do better.
Well, I actually, through this work, have become involved with some other people at Chapel Hill that are in the medical school and are working on those kinds of projects. I think it goes way back to how the institution trains medical students, and working at the beginning of the process to instill some sense of respect for the community. And although I think, you know, it's been a long time since I went through medical school, but my experience was that it was given, you know, we had courses in community and, but it was just very superficial. And it obviously wasn't emphasized as the scientific part of the curriculum was. So I think maybe shifting the emphasis and teaching from the beginning.
We just met yesterday with our Associate Dean for Academic Affairs with regards to actually bringing the Undoing Racism training to offer it for credit to professional students, and to offer it as an interprofessional education course, so that School of Law, business, government, public health, social work, medicine is still resistant. Nursing is in, that we would, and it's only like paying the trainers to come, the 2 trainers that do it, and they would do it over a weekend. So it's a 2-day weekend, so students would enroll for it, and then it's followed by 8 to 10 hours then of assignments and work with the faculty. There's a team of us who will be offering that course. And so, you know, School of Medicine is tough, and we just got our first oncologist from Cone to attend the Undoing Racism training. You know, because doctors will say, I think it's hard for many people, and especially if they're physicians of color too, to say that I need this. You know, it's to say that I treat everybody the same. I've been there, I've done that. But what they don't see is that this is about a different way of thinking. It's not unconscious bias, it's institutional bias. So, yeah.
Yeah, I would also say I'm on a CTSA partnership board at Mount Sinai, and we met with the director not too long ago, and I think the bias starts there with thinking that community is there to recruit for clinical trials.
Yeah.
And, you know, I let people know right away when I joined the board that I was not there to do any kind of recruitment. And so it's evolved over a period of time with researchers coming, especially around genetics and diabetes, to give us an idea of, you know, to summarize their study and to ask us specific questions that they have about how to implement some of that within the community. There are also a couple of projects. The Commonwealth Fund up at Harvard has a program for clinicians to understand public health and advocacy. And I know Mount Sinai, Phil Landrigan, also has a pediatric fellowship where policymakers come in to talk to you know, the fellows about being involved in community-based work. So there are a few programs here and there, but it's really that bias around clinical trials.
My name is Ernest Smith, and one of the things that you talked about was around the creation of a common vocabulary and about the language. So if you can give us a little bit more in terms of how that process was developed, because it does not sound like it would be easy, especially when we're talking about 2 different groups of people with 2 different, literally, although it seems like they're saying something, they just seem to be different.
Well, that 2-day Undoing Racism training is what does that. And so anybody who's new that comes into the collaborative has to go through that Undoing Racism training. Any research assistant that I have who's a student working on that project has to go through the Undoing Racism training. And so it provides an analysis with concepts. And so when we say prejudice, we know we don't mean racism, because it's the notion of, we say prejudice plus power then equals oppression. So And so we say that it's not possible to have reverse racism because people of color don't have the power to oppress another group.
And one of the things that we try to do is each time we meet monthly, really try and bring the focus back to the issues that we all embraced as members of the collaborative through the Undoing Racism training, to remember why we're in the room and what we're working with. So it's renewing the vocabulary also, because it's very easy to slip back into whatever your normal way of thinking about concepts is with race and racism. So we continue to emphasize that that's what we're talking about.